injury, burnout, resilience, and Western.
Don't worry about it. We're going to change gears a little bit away from fasting, but I'd like you guys to just to keep the questions you have around fasting, the comments you have around fasting in your minds. I'm going to try and finish this talk in 10 minutes because in from the audience, and I want to underline the need for scholarship from within this community, and you can see that there's a huge need. If we start talking about fasting, we're going to go on to other Islamic practices from the Sunnah that we haven't explored as an Islamic medical community across the world. So, inshallah, I feel like there's an energy in the room, and I'd like to, engage with that. So, I'm going to talk about something which is ubiquitous throughout the medical world at the moment. My premise for this is that we are at a point of an existential crisis within the medical world. I'll unfold that in a while. So I'm going to talk about the prevalence of burnout, and burnout may be one marker of the existential crisis. What has been the responses to burnout, the question of health for all, and what about the health of the individual. I'm going to talk about the existential dilemma, and then I pose a question at the end: is there a way out? Unfortunately, don't answer the question. So Dr. M is a 26-year-old man. But we all know Dr. M. He's in his second year of medical internship in South Africa. After completing most of his clinical rotations, he's considering a career change. And the reason he's considering a career change is because he's lost all enthusiasm for his work. He feels irritated when patients complain about their symptoms. He's facing pressure due to underperformance. But what he really enjoys is being out in nature, and he's thinking of retraining as a game ranger. He wants to work in the Kruger. I mean, who doesn't want to do that? Come on, you see? So I want to highlight the three things. He's lost enthusiasm, he's irritated by patients, and he's been threatened with underperformance. And for me, that immediately points to this question of burnout. And burnout, according to the World Health Organization, is related to chronic workplace stress. It's an occupational condition as opposed to a mental health diagnosis. So it's not a medical condition, and it's characterized by these three things: energy depletion, depersonalization associated with negativism, and cynicism, so he gets irritated, and reduced professional efficacy. He's just not coping in his work, doesn't get gratification out of it, and he's not performing at the level that he should be performing. So what some of the humanistic scholars have been saying is that burnout's coming from something called moral injury. Moral injury has been defined as the exposure to continuous traumatic events where you as a frontline worker experiences exhaustion. You are unable, because of reasons beyond your control, to alleviate the suffering of your patients in front of you, whether it's because there are just too many patients, you don't have the resources, you yourself are not capacitated. And the need for you as a young doctor, Dr. M's only 26, he's in his internship, he's got to prioritize at 2 o'clock in the morning, who am I going to call the ICU about? So that burden of decision making rests on this young person's shoulders. This notion of doing more with less. And what we're seeing more and more is that people are coming into our profession with a certain set of ethical principles, and those sets of ethical principles are being violated over and over again, not consciously, but purely because of the environment in which they are working. Now, one moral injury we can handle. 2 moral injuries we can probably handle. When this moral injury happens every single time you're on call, then you can imagine the chronic trauma that these young professionals are going through. Hence, why I'm saying this is an existential crisis. Burnout is the tip of the iceberg. What lies below is much more insidious. And so how prevalent is it? It's not just related to poor countries, it's not just related to middle-income countries, it's found across the world, high-income countries as well. Medical students, studies that I've looked at from the Gulf and Europe shows that between 30 to 40% of students are experiencing clinical signs of burnout. In Africa, that is up to 65%, obviously with resource limitations, much worse. Medical interns in the rest of the world, we're looking at a range between 20 and 45%. Once again, these references are available. And in Africa and South Africa, we're looking at rates of between 40 and 60%. And then in registrars or in other places we call residents, this group is particularly at risk. These are our future specialists. And if we're looking at 70 to 80% burnout rates in this group of people, then you can understand why I'm saying that this is an existential crisis. So there's been a response to this kind of, let's call it an epidemic of burnout amongst health professionals. And so there's been research which has looked at identifying what are the factors that foster resilience. Resilience has become a buzzword in the literature. If any of you have been reading the literature on burnout, we're saying that, you gotta have grit. Kind of the American frontiers type of medicine. I don't know if you're aware of that American frontier mentality. I'm going out into the unknown. It's just me, my horse, and my rifle, and I'm going to conquer the land, and whoever comes in front of me. And when I'm there, I'm going to make it. I'm going to make it, whatever. I'm going to dig in the middle of the desert and find water. I'm going to take land from wherever. So that's that mentality of constant colonization. And so a lot of the resilience literature comes out of that can-do mentality. And so people have looked at identified factors such as demographics, personality factors, social and environmental factors, social support, the type of leisure activities, overcoming personal and previous adversity, and interventions to improve, formal interventions to improve resilience, as being stuff that could maybe help us develop more resilience within our medical professionals. There's some resilience training which is formalized and incorporated into medical education, and most of them is kind of focused around emotional intelligence. How do I mitigate some of my negative emotions, and how do I communicate that to those around me? And then there's also this notion that there needs to be some type of holistic well-being interventions, which looks at coping strategies, teamwork, social support, and then interestingly also financial wellness, because once again the literature is dominated from high-income countries, and we know that the debt burden on young medical professionals is particularly high in high-income countries. So what's been the net effect of this epidemic? We are seeing the highest rate of mental health disorders amongst medical professionals of all times. There hasn't been a moment in our collective history that we've seen this level of distress amongst medical professionals. Never been recorded before. It might have been there and they were just eating brandy at the end of the day, and that was their coping mechanism, but it wasn't recorded. And we know that there's a massively increased suicide risk. Our profession, our young professionals particularly, are at extremely high risk of self-harm and suicide. We're seeing enormous rates of attrition, and all of us know of young professionals who have decided, this is not for me. They may be in the middle of internship, just finished their degree, and have decided, I'm going into business or something else. And then in many of our countries in Africa, we see the brain drain. And that's having a huge impact. We are so far behind in producing medical professionals who can care for our communities. It is just unbelievable. I mean, in the Cape Metropole, which is regarded as one of the better resourced, probably in the entire continent, we have one in the state sector, which caters for 80% of the population. We'll have one clinical psychologist, and I'm not exaggerating. If you look at the southern western substructure within the Cape Metropole, there's about 2.5 to 3 million people. One clinical psychologist post for the entire population. One. I'm not talking of private sector. If you have medical aid, you're sorted to some extent. So we're sitting in a huge crisis. Unfortunately, I don't come with solutions, but there is a broader perspective. Most of you would have heard about Alma-Ata, about Asana, and universal health coverage. And this is what the World Health Organization is propagating. I'm not critiquing it, I'm just stating it as fact. 1978, Declaration of Alma-Ata propagated the idea of health for all, the idea of comprehensive health coverage, that everyone everywhere is able to enjoy the highest possible attainable standard of health, and every resource that we have needs to be geared towards that. Great, noble intent. I'm not critiquing that, I buy into that. And then coming out of Alma Ata and Astana, we have this notion of universal health coverage, where all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. So if you look at the health economy literature, they speak about catastrophic health expenditure in poor communities. So let me just explain that for a moment. I developed pneumonia, but I'm the breadwinner in my family and I'm a bus driver. My bus driver salary looks after my family on a week-to-week basis. The pneumonia that I have is going to put me in hospital for a week and disable me for another 2 weeks afterwards. The catastrophe is that there's no income in my family for 3 weeks. So in communities at risk, universal health coverage is a non-negotiable. We cannot allow that the health cost starts to impact on the entire family and the extended community, because you have this ripple effect through communities. And so the argument for UHC is really quite strong. And so NHI kind of tries to fund that, and I'm not going to get into that here. So, but just broadly speaking, UHC then to me is an expression of utilitarianism. There's always a philosophy behind the plan. So the plan is UHC, the philosophy is utilitarianism, which says, so utilitarianism comes out of a way of thinking called consequentialism. Consequences are what drives our intention, what drives what's regarded as the moral good. So that action is determined by how good the consequence is. The goodness of the action is determined by the goodness of the outcome. Not inherent to the action itself, but inherent to the outcome. And so, some of the key issues that utilitarianism would say is that happiness or pleasure as an outcome is important, pain and discomfort as an outcome is important, but then what we're looking at, a successful utilitarian approach, benefits the greatest number of people in society. That's UHC. So we're looking at big numbers. Now, sounds great. It is great. Here's the problem. What about Dr. M? Because Dr. M is an individual within the system. And so, Dr. M has been raised from when he was 1 year old, 2 years old. His parents says, my son, you can be whatever you want to be. Here are all the resources that you need. Go to the best schools, to whatever sports you want to do. We'll put extra tuition in place to make sure that you are achieve your full potential, because you are at the center of our universe. And so, interestingly, in South Africa, we have a liberal constitution, but we have some utilitarian or socialistic ideals. And so, this nexus between, when we speak of postmodernism, which is the type of thinking that Dr. M has been raised in, it's kind of a dominant Western model theory at the moment, and where it's focused on promoting the optimization of the health of the individual and the potential of the individual. And according to the US Bill of Rights, certain unalienable rights that among other these are life, liberty, and the pursuit of happiness. And that sounds like plausible. That's quite cool. But if you think about it in terms of health for all, universal health coverage, then to my mind at least, there exists some type of moral problem. An ethical moral problem. It's not, and so when we're sitting with an ethical dilemma, we're not sitting with good versus bad. Understand that? So in ethical reasoning, when we speak about a true ethical dilemma, we're looking at two potential things which are both good. So in this instance, UHC is good. The utilitarian approach is good. At the same time, we recognize that the rights of the individual must be honored. But Dr. M, the young medical professional, sits at the nexus where these two ethical theories are colliding in the clinic, in the emergency center, at 2 o'clock in the morning. These two theories are colliding in real time. And they collide repeatedly over and over and over again. Dr. M doesn't have the right to tell patients, I'm really tired now. I I've been on my feet for like 12 hours already. You know, just give me a break for 4 hours, I need to go take a nap. Can you just imagine? The system doesn't allow that anywhere in the world. And so, this existential dilemma, which is actually an ethical dilemma, is going to result in ongoing moral injury on a grand scale. Now, the evidence has already been presented. And so, this is the idea I put before you today. I don't have an answer to it. It's just my observation. That we sit at the nexus, at this point in time, we're sitting at the nexus of these two very powerful ethical theories. Now, this is all existing in the abstract, but we see it manifesting in real time. We're sitting at the nexus where these two are bashing against each other, and it doesn't seem as if any one of them are going to give way. And so, the first thing I want to ask you, is this hypothesis correct? You're the first audience I'm talking to about this. It's been in my head for a while, but maybe some discussion about that. If not, don't tell me I'm wrong, and then you don't tell me why I'm wrong. And then, if I'm right, where do we go from here? And so, just to round up this presentation, we're in an existential crisis. The transition to new ways of thinking and being is influenced by external and internal factors. And how do we engage consciously with this transition? Or are we just going to be like surfers, we grab whatever wave we're on at that point in time? And then the more pointed question is, how do we as Muslim healthcare professionals contribute to this much broader conversation? Just like that.
So, we thank both speakers for the very insightful, comprehensive, and indeed thought-provoking presentations. I open the floor to some questions. Who would like to go first? Yes.
All right. I just wanted to ask, for those patients that are diabetic, that are renal failure, as well as the patients that have the renal failure, obviously the Ramadan is a dry fast, so there's a risk of dehydration effect on the kidney. So I want to know, in your nutrition guidelines, would you recommend intermittent fasting? Would you recommend intermittent fasting? And would it improve the hypertension and diabetes, considering the fact that they are able to drink in that?
Yeah. I mean, so that's a good question. I think Khalid did more reading around intermittent fasting than I. But my reading of the Ramadan fasting literature speaks to the relative dehydration. 8, 10, 12, 16 hours, that is harmful. So if they did intermittent fasting, the potential is that there could be some benefit for them. They need to maintain hydration. But remember also that there's other literature that shows that when you're doing fasting with pre-existing target organ damage, the benefit is non-existent. But once again, that's not high quality evidence. The evidence is not great. So I think there's room for lots of work in this field. And so, you know, we should be having conversations. I mean, the point of the IMA conference is to have these types of conversations, to start mapping out ways that we can work together collectively to answer some of these big questions.
Assalamualaikum. Allah has a very enlightening and philosophical engagement. Now, my question is this: how do you reconcile the Islamic fiqh principle, Jewish principle, whereby the public maslahah benefit takes precedence over the personal benefit?
I said I don't have answers. but I think those are exactly the types of conversations we must have. What's the evidence for saying that the public benefit supersedes the individual benefit? Is that an absolute statement? Is it true for every single scenario? Or are there some scenarios where the individual considerations overweigh the collective? You know, I mean, so the danger for me is to dichotomize the conversation. What I mean by that is we think that there are only two choices. In reality, there are other choices. Think of these two options as two ends of a polar spectrum. So on the one hand, we're always going to foreground collectivity. On the other hand, we always foreground individualism. But actually, there's an entire spectrum in between that we can say there are relative commitments to the individual versus the collective, and relative dominance of the collective over the individual. And each of those needs to be determined on its own merit. So I think, but that's exactly where the scholarship comes in. We don't just make these things up. We need to, and scholarship typically engages these discussions in a nuanced way. We can't be dogmatic and one-dimensional about our scholarship.
So if I could just also add something from an Islamic perspective as well, I think I think also comes to a balance. I think there must be a balance between self-care and duty as well. And I think, as psychiatrists, we often speak to people about self-care, because if you don't look after yourself, you're also going to get burnt out. And I always use the example in the prophetic tradition, when the Prophet ﷺ used to be, when he arrived at Medina, he used to get so busy. Everyone wanted a part of him. There were delegations coming to see him, and he ended up not having time for himself. He had a huge family as well, and there were times where he instructed Bilal that he's going into his room, and no one was to disturb him for an hour or two. So whether it was his wives, whether it was Abu Bakr or Umar, Bilal used to stop everyone from coming, because the Prophet ﷺ also needed his own time. Okay, so I don't know if that answers, but I think maybe there always needs to be a balance. And again, that is an example from the Sunnah that I can answer.
My name is Samir. Is it possible for you to put up the slide, the definition of the burnout? It's not a comment on that. I'm an occupational medical doctor, and I'd like to go back to that scenario of Dr. M. And that's in my workplace. That's what I do every day. It's my bread and butter. I used to see a lot of these interns, and you just the definition of I think that's fine. Yeah. And you mentioned that it's an occupational condition, not a medical condition. But I'd beg to differ on that a little bit, because eventually a lot of these, very typically, these interns are in that situation where they have. You must remember that an intern has trained for 5 or 6 years and is now working as a doctor. So his personality and his attitude hasn't changed over that time, but suddenly in this work scenario, all of these things are now manifesting. He's now irritable with his patients, he's not kind to them, he gets angry. That's not the problem of the patient, and this is a sad situation in which any doctor would find himself in. So that shouldn't be happening. The reason that's happening is because it is related to a medical condition which is related to a lot of the stress the person is. So typically they have very little sleep. They're overworked, they don't have support from their colleagues, or they don't have enough interns with them who have been employed. And they probably ignore their nutrition as well. So all of these things are creating a biological problem in this person, which is related to stress. And we know that the biology of stress is very complex. It's cortisol, all of these things that can manifest in this presentation here. So the problem is eventually, and I'd like to compare the employer, in this case is usually the state. They are an employer, just like any other company out there. Now, in the world, in the commercial world out there, companies get awards for being the best companies. And a lot of the best companies are there because the management is excellent and they look after their people. So in the government setting, that doesn't happen. So you're an intern, you're the only one looking after 60 patients, you're burnt out, you're irritated, you can complain to anybody, they will not give you a new intern to help you. The solution to the problem is really the employer. That's the problem, and that needs to be addressed.
Shukran. You're completely right. This is the ICD-11 definition. that you're seeing, and which has been adopted by the World Health Organization. So it's important to think about it like conceptually, burnout versus depression versus anxiety versus a formal DSM-5 diagnosis. So burnout is not a DSM-5 diagnosis. Yeah. And it's not also coming from something which is internal to the patient. As soon as that person leaves that job and they take a 2-week holiday and go sit in the Kruger, maybe with their friend Dr. M, who's now a game ranger, then these symptoms disappear, they reconnect with nature, etc. Without any medication. But I think there is research which is showing, starting to show correlations between burnout and major depression, which is now starting to link it to the DSM-5, which has now, then we start medicalizing. So it's a fine line, I agree with you, but I just quoted the ICD-11 definition.
I could also just respond, yeah, by the time the burnout patients come to the psychiatrist, they are already depressed. And I think what's happened then is that the work stress goes home and it causes problems in the work environment as well. But it's a good point and an important point, because sometimes patients don't, as part of that moral injury, they won't admit that they're depressed. I get patients who come to me, "No, doctor, I'm not depressed, I'm burnt out." Okay, but when, as Tasleem said, when we want to book you off for 6 months and we fill out the form to the insurance company to say that you're burnt out, it gets declined because burnout is not an illness. But the patient doesn't want to admit that they are actually depressed as a result of the burnout. So I think it's a very good point, and I think the insurance companies, you know, if we put burnout, they say, well, that's not an illness. So it's a very important point as well.
I just thought that it's very gender based. People that are fasting are found to be very angry.
Can I just respond? So there's some descriptive studies that speak to that. The irritability has only been documented in the first week of Ramadan. When they start measuring mood scores, from the second week of Ramadan they start to improve. So it's the adjustment. So what should happen is you should fast, your nafil fast before Ramadan. By the time Ramadan comes, your mind's in the right place.
So I think that it's very important not to be careful about labeling people. And also, because it's not, burnout is not, I'm trying. Okay, because the DSM-5 doesn't allocate burnout as a condition, but those are the very people who will see the burnout. So there's a huge overlap, but I find also with my experience with working with interns that the labeling is a huge problem, and we should do things to try and demystify that, not only in our profession, but with future application, and how it can change people's their perception in public.
To both speakers for lovely presentations. Just a question, how much of this is environmental? So there's been a change over maybe the last 20 to 50 years with regard to this, as you mentioned. Could it be because of lack of resources? Could it be because of corruption? Could it be because that there are no veg posts anymore, posts that funding has gone? Could the reason for semigration and immigration be because of the fact that the healthcare system has been deteriorating? Have those factors been looked at? That when we worked 20 years ago, there were more of us, there was more funding, there was more help, there was more resources, whereas now those are somewhat and thus the decisions to go into healthcare has been a bit of a quandary for many students wanting to go into this profession.
So I think that's partially true. But if you look at the burnout stats from across the world, in high-income countries where they don't have the same resource issues that we have, they're still seeing the same levels of burnout. So I think the problem is more than just resources. Resources play a role. It's part of the ongoing environmental stressors. But you must also remember that people bring a lot of baggage into the profession. And so the longer-term mental health issues related to depression, anxiety, etc., pre-exist a traumatic workplace. And so when you bring that into the workplace, it becomes exacerbated. But I do agree, environmental stresses play a role, but I think there's something more than that.
The term burnout has also been called compassion fatigue, where the giver is giving all the time, not care. And he needs to care for himself as well. It's not an unknown. It is suggested, first of all, what one should do is always keep up with what's happening in the field. Secondly, keep in touch with colleagues, like in meetings like these, etc. Keeping in touch. Thirdly, what Khalid mentioned about having balance together. Work, family time, leisure time, time with your colleagues as well. I found that this so-called burnout and compassion fatigue resulting in this deficiency in the care is due to the person working too hard and not having enough time for not leisure in the normal sense, but even meeting people, changing activities. The pressure is not what they need. It's commoner, I found, in private practice, when one is relatively isolated. I wonder what you think about that.
So there's interesting. There's a lady called Diane McKenna from the stage. She has what she calls a socio-ecological model of resilience. And it's exactly what you're saying, that our sense of resilience is partially influenced by those people around us. So the way I think about it is in very simple terms. I can take a good intern, like maybe one of my above average interns, and put them in a very busy emergency center, but they will work alone. Versus my average intern, and I put them into an emergency center where they have good support. Who's going to last longer? The one with support. So your skill and your knowledge levels are not as important as the type of support that you have. What is the socio-ecological framework within which you are working, which is supporting you? Not just in work, but also outside of work. So I think social support, for me, becomes one of probably the most important factors that we need to think about.
And that's why the private